Welcome, everyone. We'll get started in about a minute. We're just letting everyone in. All right, well, let's get started. So thank you so much for joining today's Webinar Wednesday. My name is Ashley Mueller, and I'm the Manager of Educational Programs at the National Board of Public Health Examiners. So this year, we are celebrating 15 years of certification at NBPHE, and in that time, we've certified over 12,000 public health professionals. So we're excited for you to be here today and also be a part of our community. So with that, I would like to introduce today's topic, which is public health leadership in remote and low resource settings, increasing capacity for health promotions, presented by Dr. Ekua Agyemang. Dr. Agyemang is a public health and preventative medicine physician specialist. She currently works as Deputy Chief Public Officer for the Department of Health, Government of Nunavut Inuit Territory in Northern Canada. She received her MPH in 2017 at the University of Alberta, Edmonton, and a certificate in population health management from Johns Hopkins Bloomberg School of Public Health in 2021. She has over 10 years of working in remote and low resource settings, addiction and mental health, and promotion and protecting health and equity-seeking programs. So with that, I would like to turn it over to Dr. Agyemang.
Okay, thank you very much, Ashley. And everyone else, thanks for coming this afternoon. It's a real pleasure to be here. I hope that at the end of today, we will get a sense of how we feel to have to be a leader in remote and isolated communities. And even as we go along, one thing I'd like us to bear in mind is that mostly remote and isolated communities are also places that are probably underdeveloped. So even though it might be in, say, Canada or the US, it will still be, the level of development might be way behind that of the general population. So talking about remote and isolated communities, also be thinking about low resource settings and then developing areas, even in the developed world context. So I'll start with a land acknowledgement. So I live and play work in Inuit, Nunavut, which is a member of the 4 Inuit. It's a land of vast tundra, as you can see in the picture, frozen landscapes, resilient communities of the Inuit people who have stewarded it for generations. So in the spirit of reconciliation, I'll acknowledge the painful history of colonization, forced relocations, as well as the cultural suppression that people have endured in the past, and the resilience, self-determination that comes with it, and amplify their voices. So I pray that the northern lights will dance across the sky, illuminating your paths this afternoon, wherever you are dialing in from, or evening, if it's that for you. Thank you very much for coming this afternoon. Okay, so a bit about myself. With regards to conflict of interest, I have none to declare. And also just want to give a caveat that this is going to be based heavily on the Canadian context. So it might not necessarily apply to the United States context, but I believe public health is public health, regardless of the jurisdiction. And there is a lot that you can take from this today. So at the end of the day, we'll look at leadership, just an overview of leadership, the various leadership styles that are there, and then also look at the unique opportunities and challenges that come with northern remote and isolated communities, and how we can be effective leaders leveraging local capacity for health promotion in these areas. Okay. So when we talk about leadership, what comes to mind? First of all, it's the ability to cast a vision and influence other people to buy into that vision and follow you to execute it. So in layman's term, that is leadership. And you will see that there are several types of leadership. So according to the textbook, there are several of them, you know, from autocratic to bureaucratic, transactional, democratic, charismatic, servant leadership, transformational leadership. And I did see the questions that you sent to Ashley. Thank you very much. Those were very helpful. So in public health, as we go along, just be thinking, what kind of leadership will be most effective in public health? Or is there actually a kind of leadership style that could be effective in public health? And are there other kinds of leadership styles that wouldn't work well in public health? Yeah. So there are several leadership frameworks, but the one I like most and the one I see working in public health and also probably for remote isolated communities is the LEADS framework. That starts from leading yourself. Then leading yourself would involve, you know, emotional intelligence, having a self-awareness, being able to manage yourself, being able to develop yourself and demonstrate integrity and character in your personal life, being able to manage your time well. So that is self-leadership. And I believe that before anyone can think about leading other people, they need to be able to lead themselves, lead their own self. And that involves a lot of things. So I believe we are all self-leaders coming online this afternoon, you know, doing the personal development as public health professionals. And then once one has been able to lead themselves, then you can talk about engaging other people. So that is when you will build, you know, relationships, you will collaborate with others, you will be part of the team and also build teams. That is when communication becomes very important. And then you also need to contribute to the organization as a whole. So that engagement piece comes after one is able to lead themselves. Then through the process of engaging others, collaborating with stakeholders and partners in whatever topic that is of interest, you realize that you begin to achieve results. Because oftentimes we would engage with people with a mindset for, with an end goal in mind. So if we engage, say, since this was in the context of tuberculosis, say if you are a tuberculosis program manager and there is a tuberculosis outbreak in a community, you definitely need to engage several stakeholders across a wide spectrum. So community leaders, the community members, your own team members. And then if you're in a public health unit, you would also think about, depending on the level, if it's local, you know, federal or provincial or state level, then you will also need to engage other partners. Then it comes to achieving results. So then in achieving results, we're able to set common goals with individuals or teams and organizations that we engage with. We are able to make decisions together, able to implement these decisions and then evaluate and assess them, and then reset our direction, prioritize, and in that process, we are achieving results. Usually, most people would stop once they've achieved results. You know, when it comes to public health program management, you plan with your logic model, you design your project, you implement it, you evaluate it. But it shouldn't end there. You should go ahead to develop coalitions. So then leveraging on whatever results have been achieved, so that you can develop coalitions, looking for similar groups, organizations, people doing similar things, and leveraging your successes and their successes to make it bigger. Then comes the systems transformation. So you systemize it so that this can last. It can become a framework that others can also learn from. It can become a part of the system. It can become a structure that anyone can take and follow and then see results. So when it comes to public health, this is the leadership framework that works really well, at least from my point of view. You might have others that you might have encountered. And when it gets to the questions time, or even now, feel free to put some other frameworks that you've encountered, that you've used in the past, that has really worked in the chat. So what is the difference between leadership and management? I'm not sure if people are able to talk now, but you can just put it in the chat, or maybe wait a couple of minutes and see what people put in the chat. What do you think are the differences between leadership and management, or a leader and a manager? Are they the same things?
So everyone should have access to chat.
Okay. Someone says that leaders invite to follow, manager demands tasks. Okay, good one. Any other point of view? Leaders create vision. Okay, that's a great one. Leaders focus on the vision. And what do managers do? Leaders are visionaries who guide goals, and managers are the individuals who assist with the day-to-day management. Okay. Any more views? Leaders have investment in your team and reciprocity. Okay. Managers focus on task. Okay. Leaders encourage new ideas and innovation. Leaders mentor, promote staff growth. Okay, so it looks like we have a general sense of the differences between leadership and management, or what a leader would do and what a manager would do. And someone says that leadership demonstrate and should include strategic development and vision. Managers should encourage, should ensure their programs and personnel have what they need to create success. Yes. So leadership is that high level piece, and then management comes to the granular details of what it takes to fulfill that vision. So it looks like you've all captured it very nicely. And actually in northern, remote, isolated, low resource areas, if you are, say, a public health manager, you won't only be a manager, you would also have to be a leader. You know, so you find yourself doing most of it at the same time. So I like to think that leaders could just be leaders, right? But oftentimes, to be a good manager, you also have to be a good leader. Well, bearing in mind that, you know, the LEAS framework, no matter what level anyone is, they still would be a leader of themselves at least. But once you're a manager of a team, you also need to be doing a bit of that leadership piece, looking at what the vision for the group is, what is the purpose, motivating people, encouraging them. Because if you're only a task master who is focused on strategy and productivity, chances are that your team members, you might lose them as time goes on, or people will be demotivated and drop off. So to be an effective manager, you also have to have some of these leadership skills that are listed here. You know, to be a good model yourself, be creative, confidence, show humility, create a vision, definitely huge one on interpersonal skills, prioritizing, continuing education, and then developing your followers. So when it comes to leadership and management, one thing that we cannot get away from is the conflict resolution. And there are several ways to approach this. This is just an acronym that comes to mind quickly whenever there's conflict, whether interpersonal or at the organizational level, whatever it is. And I'm sure that in your day-to-day work, you encounter conflict. It might not be, aggression and violence, but just difference in opinion or wanting one outcome whilst another person wants a different outcome. But whatever it is, it's important to establish what the rules of engagement are, that is going to be respectful. People are going to communicate maybe in email, so you're going to have a meeting. You'll gather the information that is needed, try to identify what the actual problem is, what the needs are, and then, assess potential solutions. Sometimes it might involve negotiating because it might not sit well with one party, but eventually there'll be a solution. So when it comes to conflict, again, there are 4 main ways that people deal with conflict. Some avoid it. So we have the avoidance, and then we have the accommodating, who would, even though it's not the best, they will still, because of the sake of the relationship, they will accommodate that option. And then there is compromise, which is you are not 100% happy with the solution, but for the sake of peace, you let it be. And then there is, the best, which is collaborating. So once you collaborate, everyone puts their cards on the table, everyone puts their needs on the table, put their fears and concerns on the table, and then respectfully you talk through them and come to a solution which is a win-win for everyone. But there is also a way of addressing conflict, and sometimes in leadership, there's a place for this, which is competing. For instance, if you're a manager and you have deadlines, there's productivity issue. And then you have an employee or a team member who is, giving excuses, not pulling their weight. You would take that competing approach in that you might set in motion, the cycle of discipline. So maybe give a verbal warning, give a written warning, maybe find out if it's a competency issue, give them some more training. If it's a personal family issue, give them the support that they need. But if it's just not working, or if it's just, just right out crime like fraud, then competing issue in the interest of your team, you probably would let the person go. So there is a place in leadership for all these kinds of and approaches to conflict resolution. And I invite you to think about yourself and how you approach conflict generally, and what style you might be using. What is your default conflict resolution style? And what other conflict resolution styles could you probably look into that might help with your leadership journey and with your being a team member or being a manager or being just a good person to live with. So I would invite you to think about that as we go along. So now the northern remote isolated community. So I live in Inuit, Nunavut. It is it's close to the Arctic Circle. So Nunavut, part of Nunavut is in the Arctic Circle. It's all 25 communities, all fly in, surrounded by sea in the summer, but the seas are mostly frozen for a greater part of the year. In the winter, you probably get 2-3 hours of sunlight. In the spring, summer, you get sunlight the whole time. So there are some communities that even have like 24 hours of sunlight. They just have 1 hour of darkness at some times of the year. And then the same way, the opposite, sometimes too, they do have darkness the whole time. So if you live in such an environment, the geography itself, it's an issue, right? So the geography itself is a big deal. People having to come to work every day, people having to come to work every day, it's a huge thing. So imagine that it's 24 hours of darkness, 24 hours of sunlight. Some people who have seasonal depression will probably go into depression. That is real. And some might also stay up the whole time. So they are not sleeping well, they are not having enough. So all these are things to consider when you live in remote, isolated communities. The geography itself might come with its own challenges, right? So then we've talked about conflict resolution here, but the next slide we'll go more into detail about the kind of communication styles in such areas. And then, of course, as I said earlier on, most isolated remote communities also tend to be underdeveloped, might be indigenous, might be maybe Black African communities that are much less developed. So there's the need to have that cultural sensitivity and to approach things from a place of cultural safety. And then also to be mindful of trauma-informed leadership. So being aware that individuals from such places it might be personal trauma or even communal trauma like colonialism, or even trauma that is ongoing, suicides in the community, the poverty, and all other social determinants of health that come into play in such communities. So this is one thing that knowing has really helped with my leadership style. So in Nunavut, it's about 85% of the people are Inuit. And if you look at the high context communication and low context communication, you realize that indigenous people, most part of Asians and Africans, and even some parts of the Middle East are high context communicators. And what does that mean, right? Also, US, Canadians, Europeans, typical white people are low context communicators. And that is, communication is explicit and direct. So a Canadian or American will come and say that I need you to do this work by this time. And they have communicated clearly what they want done with the deadlines, and they expect you to follow through. In a high context communication culture or environment, it's implicit and indirect. So even though they would like you to do this, they'll come across like, oh, are you able to do this? And sometimes it's also difficult for people to say no. So they will not tell you no directly. They might answer with, another thing. For instance, a high context manager comes and say that tomorrow we have a conference coming up. Tomorrow is Saturday. Are you able to come in for maybe 2 hours to help with the conference planning? And say the manager is from a high context culture, so it's a Canadian. And the employee he's speaking to is an Inuit person, for instance, or indigenous person. And they will answer and say that tomorrow is my son's birthday. Are you able to come in and help tomorrow? Tomorrow is my son's birthday. And then the manager goes like, oh, happy birthday to your son, and then goes away thinking that this individual will come. But the response that tomorrow is my son's birthday is an indirect way of telling you that, no, I am not coming tomorrow because tomorrow is my son's birthday. But because of the difference in culture, you might not get that. And then Saturday you show up as a manager and no one comes. And then you are wondering, what happened? This person is irresponsible. You want to take disciplinary action. But then, because they, in their mind, they communicate to you that they were not coming. They told you that tomorrow is their son's birthday. So it's important to understand some of these differences, high context, low context. Again, in high context environments, when there's a disagreement, people will not, like people will just stop work. They will not, you will not even see them. They will not come to you and tell you that I was unhappy with what he said. They will just not show up, and that is it. And you will just be on your own as a manager. So you need to understand, be aware, and approach conflicts from that point of view. Again, it's more of a centralized system, and everything thrives on relationships. So very important that we have this at the back of our mind as we go along. So it's another thing that I became aware, you know, before I came to Nunavut to work as the chief public health officer, I was working in a city which was more of, you know, Americans, Canadians, Europeans. So more low context communication in the office environment. Here in Nunavut, especially in the spring, and just last week I had this example. So someone texts you that, oh, I came in from fishing late this morning. And then after a couple of hours, so they are not in the workplace. They are sending you a text telling you that they came in from a fishing trip late that morning. And then later on, they text you that, oh, there are seals in the bay, or someone invited me to go seal hunting. It's like, forget it, they are not showing up that day. So you need to find out what are the outstanding tasks that I need from this person. And then just reach out to them and say that, okay, yeah, I hope you found some fish on your fishing trip. And then you quickly push in, okay, these things are outstanding. Can you please check on them when you have a moment? And then that. So once you understand, you know, the culture and the context, you be able to get what you need from them. Because again, once they are committed to doing work, they are very dedicated, hardworking. And also because they are from the community, they speak the language. And here in Nunavut, the first language is Inuktitut. So even though it's part of Canada, their first language is Inuktitut. So children, even up to like grade 6, some of them at grade 6 are now learning to speak English or learning to write English. So it's important that when it comes to programming, health promotion, and all that is done in the language. And obviously, I don't speak the language. So they are valuable human resource that you cannot just afford to lose, because again, there's other determinants of health, you know, substance use and all that. So illiteracy, lack of education, you will not get many people. So once you get people who are qualified, who are willing to work, then you need that wisdom to manage them so that you can get the best out of them and support them when needed. So just wanted to put this out there, high context communication and low context communication. And it also affects how these individuals say no, how they respond to conflict. So like the example I gave, can you come to work tomorrow? Tomorrow is my son's birthday. It means something else. They find it difficult to say no. So might not say no. Instead of saying no, they might answer, I don't know, or maybe, or just tell you something else, but it's a no. For low context communication, they'll come out clearly and say, I'm uncomfortable telling you about this, so I'm uncomfortable saying this. So a really clear communication lines. So this is a map of Nunavut. You can see it's close to Greenland. All that blue is water. So all that the ocean, which is usually frozen for most part of the year. And then the green, the yellow, the brown, that is land. And as you can see, most of the communities are surrounded by water. So you see green, brown, and yellow. So it's 3 different regions with 3 different time zones. So it's the whole Canada is what 9.09 million kilometers square, and Iqaluit alone, Nunavut, is that much. It's more than, it covers more than half of Canada, but it's all frozen sea and little land. The actual population is just about 40,000 people now. Most communities would have 1,400, 1,500, 1,200. Some even have 500. Those very northern communities, they would have about 400, 600 people in community. So as you think about this, you can think about the determinants of health that comes with that. So this is something that was in the newspaper, 6 community health centers on reduced emergency services. So the whole territory, we have one fully equipped hospital. Most of the 25 communities have healthcare centers that would have X-ray, maybe even an operation room sometimes, some wards, and just basic stuff to allow basic healthcare, but it's not a full hospital. And because of how remote it is, sometimes it's difficult to get qualified, trained people going up there and staying in. People would go and stay a month or 2 and leave. So then this is where the opportunity is a challenge, but that is where the opportunity for building the local capacity comes in. And that is where we can leverage local capacity for health promotion. So this picture is a picture from Nauyat. That's in the middle there, that is Caribou Heads. As you can see, this is April and still there's snow covered everywhere. The sea is frozen. That picture of myself I showed earlier on, I was standing on the frozen ocean and took that picture. That's about 2 or 3 weeks ago. So you can think about that and the determinants of health that comes with it. So that picture before this, that was actual housing. And housing is a challenge because everything that needs to be constructed or needs to be built needs to be shipped in. If it cannot fit in an aircraft, you need to wait for the summer period, which is usually between like June to August. So just about that 3 months window when the sea has thawed and it's not frozen and ships can come in and bring stuff in. So there's not much that can be built year round. And usually houses there are pre-made. They only bring them on the ship and then just put it up. So no construction as usually you see everywhere. So the built environment is a big deal. And by the way, there are no trees. The whole of the territory, the climate does not support trees. So I was really surprised. There are some people who were born and raised there that have never seen trees, except maybe on TV. So it goes a long way when you think about your health promotion approaches and how you can build capacity. And then definitely there's food insecurity, because if you cannot grow stuff there, if trees cannot grow there, then food cannot be grown. So people rely heavily on hunting seals, hunting caribou, hunting Arctic char, which is the fish, sometimes whale and narwhal meat as well. And because there isn't, traditionally, there wasn't wood and trees, most of these foods are eaten raw. So they would eat the raw flesh of that and maybe with salt or soy sauce or something, but that's the meal. But so a community might have just one grocery shop, but it takes so long to get stuff in. So most of the time, the shelves of the grocery shop are empty or expired stuff, because if the ship doesn't fly in, or the plane doesn't fly in, or it's not good weather to get the ship bringing in supplies, then there's nothing. And that again comes to when you talk about human resource, not just in the health field, but also in education. So difficult to get teachers there all year round. So level of education is low. And then healthcare might also be low. And then addiction substances. And underlining all this is the history of colonialism, where people were displaced from their land when settlers came in and stripped of their culture and self-determination. So as you can see here, these are the main determinants of Inuit health. And it's important to put this in mind when we talk about leadership and capacity building. Again, when it comes to healthcare access, as I've already talked about, the geography is a big one, educational attainment of the local people, bias from professionals that come from down south, and then the employment inequalities that it's ongoing. So it's in the midst of all this, how do you then build capacity for health promotion? But I'm very happy to say that we've had some successes. So we work mainly with lay community members who have been trained to do things like health promotion, so they can talk about various diseases, educate people in the local dialect about various diseases. And the same people, usually, as I talked about, education is a big deal. So these are maybe grade 10, people whose highest level of education is about grade 10, because most do not complete high school, but then they are able to learn. So some can be trained as basic X-ray technicians. Others can be trained as public health assistants, helping with well baby visits. Others can be trained as midwives. Others can be trained as remote ultrasound, technicians. So there is a radiographer at the other side, and then they are in community, just using the probe, and someone else is connected, reading what is happening, and then making sense of it. So there've been innovative ways, and Alaska in US does have a really great model for community health aides. They have excellent training programs that are working. So for those of you in the US, that is one thing you can look at. Just look at Alaska's community health representatives and community health aides and how that program has been supporting and has been the main backbone of the healthcare system. As I said, it's difficult to get a nurse to go into community to stay for 6 months at a time, but you have a community health representative who has been in community for, say, 20, 30 years. They've learned by apprenticeship most of the things, how to do that. They know most of the people in community. So say there is a TB case, they know everyone in community. So they're able to help, very instrumental in contact investigation. So even if a nurse is flown into community with the support of a community health representative, you'll be able to do the contact investigation, and then they will go on radio, educate people about what is happening, encourage people to come to the health center and get screened. When it's syphilis, then they are very instrumental in contact investigation and partner notification. And they are like the backbone of the healthcare system. That's because the traditional healthcare workers are not able to stay long in these environments. So as I was saying, because they live in community, they are trusted by the communities, they are able to support and be the backbone of the healthcare system. And when it comes to health promotion, they are the main people we go to. All we do is maybe produce the resources, print information, train them, and then send them out. And that is the capacity that I wanted to talk about today. But as this started from leadership, if you don't have this leadership skills or knowledge, awareness background, it's very difficult to leverage the skills and the value that community lay health workers bring to the table. So it's important that we develop our leadership skills so that we can maintain human resources at any level, especially in remote, isolated communities. So I will end here and we can have some time for questions and answers. Thank you very much. So if you have questions, please feel free to put them in the chat. And I'm sure as I talked about communication, I probably answered some of the questions that people had.
So we'll give everyone a couple minutes. We have some great comments in the chat. One person said, Maria said, this presentation was so powerful and relevant to me here in the Pacific Northwest of the United States, communicating with Black, Indigenous, and people of color as someone who belongs to these groups. Thank you. So we'll wait a couple more minutes.
Okay.
And I know a lot of you had sent your questions before. So if we didn't answer the questions during the presentation, please feel free to add those back in the chat and we can talk about those further. We do have a question from Celia. This is an excellent presentation. Thank you. Are you familiar with the AmeriCorps model in the USA for developing community health workers? And is it similar to the model you described?
Yeah, so first, I'm not familiar with the American Corps model, but once it's community health workers, I believe the context is similar and the approach is probably the same. The main purpose is to get people from the community who are trusted, who are living there, probably will not leave, to build capacity to be able to do things that are very simple. Usually, and even right here, most of the time, the challenge is with legislation and policies that have been in place for years that are not really working, but the process to change them are so long and tedious, so nobody wants to touch them. So then the policy is that, say, X-ray technicians need to be regulated. But no X-ray technician wants to come to this community. And there are people in community who are willing to learn to be basic X-ray technicians with remote support. So then that once people identify such individuals and train them, that is community health worker concept. And in Africa, and in Ghana, where I used to work before I started working in Canada, that was also used a lot. So in Africa, most of the community health workers would be midwives. They would treat malaria. They would be able to quickly triage and know who to send on to a higher, health center or a tertiary health facility. And then they will be able to do most of the basic stitches and stuff like that in community. So that is my answer. I believe it's the same concept, but I'm not familiar with American Corps model. Thank you.
We do have another question. Are there any tailored public health programs that you were able to implement even with a low budget?
Yeah, so definitely there are some. And again, I'll just bring my example of the TV program. So it's these communities, as I said, only fly in, so an accommodation could be very difficult to get. So usually they would have just one hotel or one guest house in such communities, very difficult, booked all year round, so difficult to get in. There was a community that we had seen TB deaths, and it was because people were not comfortable coming to the health center, which was manned by nurses from down south. So they would, even though they've been identified as close contacts of tuberculosis patients, they wouldn't come in to get care until they were breathless and virtually on the verge of dying. And we kept seeing that again and again. And because of that stigma and that fear of, you know, the healthcare system, this kept happening. So what we did was get, we call them community engagement specialists, but they are also community members. So another kind of community health worker who speaks the language, and we sent them into that community. So once they saw someone who looked like them, who spoke their language and was giving them the information, then they opened up and listened and started coming in for care. So that, hitherto that, we would, you know, send more nurses, send a lab technician, set up a whole screening clinic, try to screen the whole community, do a community-wide screening, which is very expensive because imagine, you have to charter a plane to send all that equipment to the community, find a venue, put up a new X-ray machine and all that. But with just that health promotion approach, the Inuit person going and spending some time in community, not doing clinical work, but just health promotion and community engagement, talking to people, addressing their fears and their concerns, they were able to open up and utilize the facility on the ground. So we've kind of implemented this with most of the other communities at all. We call it the public health fair, where we would send people from the community or people who speak the language into community, and they will spend a couple of weeks with their materials doing education, engaging elders, engaging the youth, engaging children at school. Maybe they will have a community feast, and then people will come together, they'll give out prizes, ask questions, just engaging people, let them feel heard. And then they are able to then engage with the healthcare system and engage with people who are probably the healthcare workers and nurses who had come from the South in the community center. So that community engagement piece is a strong one. And it's a program that we have adopted that is helping with that hesitancy to engage with the healthcare system and to access care.
Great. It looks like we have a comment from someone in the audience that said, "Thank you for this informative presentation. I want to share an example. In Pakistan, Aladi healthcare workers have been going door to door, providing healthcare services, particularly in reproductive healthcare services in low resource areas." So this is an example she's seen. And then we have another person that said, "This is why public health has to do with collaboration with different agencies to foster care." So are there any more questions? If not, I would like to let you know that we do have our next webinar Wednesday, the second week of June. The topic will be role of cultural competence and cultural humility in the LGBTQ+ populations for public health professionals. So we hope that you will join us again next month, and we look forward to seeing you then. Thank you so much for your time today.
Yeah, thank you all for coming and listening. Thank you.